Hello everyone, I am Mrs. Golden, working as tutor in Triple College of Nursing. Today we are going to discuss about acid-base imbalance. So objectives, end of the class you will be able to see about introduction about acid-base imbalances. We are going to discuss about respiratory acidosis, respiratory alkalosis, metabolic acidosis and metabolic alkalosis. For introduction, respiratory acidosis and alkalosis, it results from the impaired respiration rate which regulates the carbon dioxide levels in the body, and metabolic acidosis and alkalosis are caused due to an imbalance in the production of acids or bases by the excretion of kidneys. The normal values of the pH are 7.35 to 7.45 and the normal values for partial pressure of carbon dioxide ranges from 35 to 45 mmHg and bicarbonate 22 to 26 and partial pressure of oxygen is 80 to 100%. So in this picture, in one picture we can see the parameters on the normal values, and in the other picture we can see the differentiation between the respiratory acidosis and alkalosis and the metabolic acidosis and alkalosis. So while we compare from respiratory and metabolic, respiratory it differs in the pH level and partial pressure of carbon dioxide, whereas in metabolic we compare that pH level and the bicarbonate level varies. So in respiratory acidosis, when pH reduces and partial pressure of carbon dioxide increases, that leads to respiratory acidosis. And in respiratory alkalosis, the pH level increases and partial pressure of carbon dioxide decreases. Whereas if we compare with metabolic, in the partial pressure of carbon dioxide in metabolic is normal, but in bicarbonate level and the pH varies. Whereas in metabolic acidosis, the decrease in pH level accompanied by the decrease in bicarbonate level, and in metabolic alkalosis there is an increase in pH level and increase in the bicarbonate level. So this is about respiratory acidosis and alkalosis and metabolic acidosis and alkalosis. So in this we can see about when there is an accumulation of acid and the loss of base, it is accompanied with the increased concentration of the hydrogen ion. So when there is an increased concentration of the hydrogen ion, the pH level drops. So when the pH level drops, it results in acidosis. Whereas if we compare with the alkalosis, there is a loss of acid and the accumulation of bases, so which is further accompanied by the decrease in the concentration of a hydrogen level. So when there is a decrease in the concentration of a hydrogen level, the pH level rises. So when the pH level rises, it leads to alkalosis. Now we are going to discuss in detail about respiratory acidosis. So in respiratory acidosis, it is a condition which is characterized by an increase in the hydrogen ion concentration where the pH level decreases less than 7.35 and the partial pressure of the carbon dioxide is increased in more than 45 mmHg, which is further there is a compensatory increase in the bicarbonate level. Here we are going to see how the body tries to compensate in respiratory acidosis. So kidneys, when it excretes more acid, there is a decrease in the pH level and the urine also becomes acidic. So when the urine becomes acidic, there is a compensatory increase in the bicarbonate level also. So conditions which lower or impair the exchange of air cause respiratory acidosis. So what are the conditions are stroke, cerebrovascular accident, medication, any medications like opioids and benzodiazepines, myasthenia gravis, muscular dystrophy, asthma, emphysema and chronic obstructive pulmonary disease, bronchiectasis, pulmonary edema, severe obesity, cardiac arrest and sleep apnea. So in these conditions we can see that the exchange of air is impaired or slower. So when there is an increase in carbon dioxide level, it leads to an respiratory acidosis. So why there is an increase in the carbon dioxide level is there is a hypoventilation, which means there is a decreased breathing level. So when there is a decreased breathing, the exchange of air is impaired, which leads to the conservation of carbon dioxide and the partial pressure of carbon dioxide is increased. So coming on to clinical manifestations. So clinical manifestations are drowsiness, and disorientation, dizziness, headache, coma, hypotension, dysarrhythmia, seizure, and hypoventilation with hypoxia. Coming on to management, we can administer oxygen as prescribed by doctors, place the client in a semi-bolus position, encourage the client to perform the deep breathing exercise and coughing technique where it promotes the carbon dioxide exhalation, so which further prevents from increase in the carbon dioxide levels. Encourage the client to drink plenty of fluids which can liquefy the secretions in the lung to improve the ventilation, to perform suctioning if there is more secretion, monitor the electrolyte and ABG analysis values, prepare the patient for the endotracheal tube and mechanical ventilation when there is a further increase of carbon dioxide level above 50 mm of Hg. So next we are coming on to the respiratory alkalosis. So in respiratory alkalosis, it is a condition where there is a decrease in the hydrogen ion concentration resulting from an increase in the pH level and a decrease in the carbon dioxide level. So the pH level is increased more than 7.45 and the carbon dioxide level is decreased less than 35 mm of Hg, and there is a compensatory decrease in the bicarbonate level also. So causes, when there is an overstimulation of the respiratory system and hyperventilation. So in hyperventilation, so when the person breathes rapidly, there is a exchange of carbon dioxide, the air, which is let out. So the carbon dioxide level is decreased. Next one, fever, which can increase the rate of metabolism and stimulate the rapid respiration rate. Hypoxia, which stimulates the respiratory center and thus results in the hyperventilation. Hysteria, whereby vigorous forceful breathing can be observed. Pain, which can increase the respiratory rate and depth. Hyperventilation by mechanical ventilators. So here so far we can see that hyperventilation leads to the decrease in carbon dioxide level. Why means, in hyperventilation the person breathes rapidly. So when the person breathes rapidly, there is an exchange of air let out. So when there is an exchange of air is let out more, the carbon dioxide level inside is decreased. So next one, coming on to the signs and symptoms of respiratory alkalosis: lethargy, confusion, tachycardia, dysrhythmia, nausea, vomiting, epigastric pain, tetany, tingling sensation in the extremities and numbness. So coming on to the management, place the client in the rebreather mask, encourage the client to rebreathe into a paper bag to provide a carbon dioxide breath. We can give sedatives and tranquilizers, pulse oximetry to check the oxygen level, pain management and decrease the ventilation rate. Next one, coming on to the metabolic acidosis. It is a condition where the total buffer phase is less than the normal and there is a relative elevation in the hydrogen ion concentration. So in this metabolic acidosis, the pH level decreases and the bicarbonate level also drops below 22 milliequivalent per liter. So the causes which can lead to decrease in bicarbonate level are loss of bicarbonate through diarrhea or renal dysfunction, or when there is any accumulation of acids like lactic acidosis or ketones, and when the kidneys is failure to excrete the hydrogen ion, it leads to the decrease in bicarbonate level and the elevation of the hydrogen ion concentration. In this picture we can see that when the metabolic balance is there before the onset of acidosis, means the ratio between the carbonic acid and the bicarbonate is 1:20. So whereas when there is a metabolic acidosis, what happens to the ratio is the carbonic acid, that is the bicarbonate level, decreases due to the presence of ketones or chloride or any organic acid ions. So when there is a decrease in bicarbonate level, so before the onset of acidosis we can see the ratio is 1:20. So when there is a metabolic acidosis, the ratio decreases to 1:10. So how the body tries to compensate is, it tries to excrete the carbon dioxide level, in turn to increase the bicarbonate level. The causes of the metabolic acidosis are when there is a loss of base or retention of acid, diabetes mellitus or diabetic ketoacidosis, when there is a high ingestion of fat diet, insufficient metabolism of carbohydrates, ingestion of acetyl salicylic acid which can cause more hydrogen ion concentration, malnutrition which results in impaired catabolism and diarrhea. Coming on to signs and symptoms: drowsiness, confusion, headache and coma, hypotension, dyslipidemia, nausea, vomiting and diarrhea, abdominal pain, Kussmaul's respiration, warm and flushed skin. Coming on to management, we have to treat the underlying cause. In diabetic ketoacidosis, when there is a case of diabetic ketoacidosis, we can go on with fluids and insulin. So when there is a patient with chronic renal failure, we can go on with hemodialysis or peritoneal dialysis. We can prefer a low protein diet and high calories which can reduce the protein waste products. Oral bicarbonate and IV sodium bicarbonate, that is 2 to 5 milliequivalent per liter, can be infused over 4 to 8 hours, and subsequent doses can be based on the patient acid base status. Next one, coming on to the metabolic alkalosis. So in metabolic alkalosis, it is a condition where the pH level and the bicarbonate level both increases simultaneously, whereby the carbonic acid and hydrogen ion deficiency results from accumulation of base and loss of acid. So the bicarbonate level increases and the pH level also increases. Coming on to the causes: gastrointestinal suctioning, excessive vomiting, hyperaldosteronism, ingestion or infusion of an excess sodium component, massive blood transfusion, usage of more diuretics. Coming on to the signs and symptoms: drowsiness, dizziness, nervousness and confusion, tachycardia and dyslipidemia, anorexia, nausea and vomiting, tremors, muscle cramps, hyporeflexia, tingling sensation in extremities. Coming on to the management, we have to monitor the ABG analysis values. We can assess the serum electrolyte values. We can monitor the client for the feature of any respiratory distress, administer the intravenous therapy to promote the renal excretion of the bicarbonate in order to prevent the conservation of the bicarbonate, administer the potassium supplements, stop diuretics or alter the diuretics when it is prescribed more. Thank you all.